Hey everyone, it's Adam Farkas. Welcome back to another ODwire webinar. Thanks for coming out tonight. Tonight's talk is all about visual fields and doing fields testing. And I guess the dirty secret is that we all know is that field testing for patients can sometimes be a pain, right? I don't think I'm saying anything surprising with that. It can be difficult for patients to do accurately. It can take a long time. I also know that in terms of a footprint in your office, sometimes the field tester can take up a lot of space. So it was sort of gratifying to see, after being sort of trapped away during the pandemic and not going to any trade shows last fall, I went out to the academy, and lo and behold, what did I see but a plethora of new devices that use virtual reality to do field testing. So it was great to see that this has actually become a viable option. And tonight is sort of all about this technology and learning about it and how you can implement it in your practice. And to help us learn all about it tonight, we have the great Paul Karpecki, who scarcely needs an introduction here, but I will remind you that not only is he the medical director of Kepler Vision, but he's also practicing OD, the director of cornea services at Kentucky Eye Institute and Center for Sight. And most importantly, I believe everybody knows him as the chief medical editor for Review of Optometry. He's published dozens of peer-reviewed articles, hundreds of non-peer-reviewed articles, and even 7 book chapters. So he is the ultimate authority, and I'm so happy to have him here tonight to talk to us all about this new technology. So with that said, Paul, why don't you take it away?
Thank you, Adam. What a great introduction. I'm going to echo a few things Dr. Farkas said, such as the fact that, this is innovative technology. I'm really glad you're part of this. I think that, as he said, welcome and being here tonight, but also the fact that when you have this opportunity to learn about new things, I think it creates this wonderful situation we don't have for a long time that sets you apart, that allows you to look at new things, differentiate your practice, and help patients. And this is one of those technologies. And he's right. It's funny, he told that story about having been away for a little bit, and I did the same thing. I hadn't been at any meetings and looked at all these new technologies that evolved. And this virtual reality space is an ideal fit for medical measurement diagnostics, and in particular, visual fields. So we're going to talk a lot about that today, a more efficient approach to visual field testing. But I think as you hear this, you're going to realize and recognize that this really does make a lot of sense. This is the wave of the present, not even the future. This is where we want to be today. So I'm going to take over here and start advancing. So we're going to go through an introduction to the technology, a little bit about background of visual field test, what we've done up until now. We'll talk a little bit about some of the key attributes that we look towards these technologies, such as finding ways to increase comfort, decrease anxiety, to be able to overall get better quality tests, the reliability that comes in with active eye tracking in particular. And I think the reason I love that at the beginning, because that's a real differentiator. It is that's something when you're looking at these virtual reality systems, you really want to have something that has active eye tracking, not something that just has a dot that they're supposed to look at or a crosshair. I want to talk about neighborhood cluster testing. I think this is very important in the new wave of understanding of visual field testing. And there's so many clinical references and so many papers around this whole area of neighborhood cluster testing, how it improves not only speed and efficiency, but even accuracy, because there's not that patient fatigue. And for those who aren't familiar with this terminology, I want to cover that tonight as well. And then really the key benefits of the Smart System VR headset and how it takes into account what we talked about. And then we'll open it up for Q&A. And I'm lucky tonight to have Mike with me too, who's a true expert in this area who can answer a lot of those clinical questions and help out as well. But I'll certainly answer it from the standpoint of practical and practice and clinical in that aspect of utilizing these technologies. So we're going to go ahead and begin. As we start out here looking at, well, we've already covered me. So let's go in the background of visual fields and where we've been all these years. And we know that they're critical. You couldn't really practice optometry effectively if you didn't have a way to measure visual fields. Not only do they detect scotomas, they also check for peripheral vision loss. And the key importance of that is it's the ability, well, primarily to diagnose and monitor glaucoma. We couldn't really effectively manage glaucoma if we didn't have visual field testing. But it goes beyond that. In order to qualify for insurance coverage of maybe a patient who's looking at having a ptosis surgery, blepharoptosis, you have to have a certain level of visual field loss for that to be covered. Those who don't apply could possibly even use some of the newer drops now, like Upneek and other things like that. So it's a valuable test to determine who qualifies versus topical agents. You can monitor for diseases of the retina. In fact, in particular, we talked about the neighborhood cluster measurement, which I'm going to go into. One of the great applications besides glaucoma is in retinitis pigmentosa. It seems to be more predictive of the patient's outcome when you do cluster testing. And so we're going to go into that and how that fits in. Optic neuropathies beyond glaucoma. And of course, if someone's had a stroke or space occupying mass in their brain, that can obviously affect the pathways resulting in a visual field loss. So we know that this is critical to how we practice. We understand how important it is to be able to detect visual field loss, and we can then attribute it to some sort of pathology ranging from optic neuropathies to retinal diseases, strokes, tumors, and of course the most important application we automatically think about, which is glaucoma. Now, one of the more interesting areas is just to look at where we were and to try and see what we can make better, how we can help our patients, what we can do to help our practices. And Dr. Farkas is right. If you look at, there's a survey that looked at the tests that optometrists do that patients felt were the most tedious or the most difficult and the most anxiety inducing of all tests. And I guess we should look at that to determine where we have to improve. And ironically, the two were refraction, not in any order, but refraction was one of those two. And I think it's because everything seems similar when you get to one or two at the end, and you're trying to find that medium spot. And of course, the other one was visual field testing. So if there were two things we could try to improve for patients, this probably would be their key points that could differentiate us. I honestly think that refraction we do quite well, and probably it's not as much of a pain point, but visual field testing certainly is. And if you look at this list here, you get a pretty good idea why patients would put that down. Number one, you got to go into a dark room, and you're required that extra room. And not a lot of practices have a lot of space to be able to dedicate the room to, but that was our only option in the past. It's uncomfortable for the patient. As you look at the patient in the left image there, you can see that just sitting there for 12 minutes per eye, or even with some of the faster tests where you get down to 8 to 10 is still a long time, and that makes it uncomfortable. Studies do show very clearly, and there's a great study there by Barkana that showed that fixation loss has a significant compromise of the reliability or the accuracy of the test with these dome type visual field tests. It's limited to monocular testing, but that goes back to that uncomfortable time. You do one eye, and then when that's finished with your 24-2 or 30-2, if you want more accuracy, you then go to the other eye. And so that's that doubling of time that takes place. And even with some of the fast systems and C2Fast and others, there's still quite a bit of time when you have to do each eye individually. It also uses single test points. And although that seems obvious, we say, hey, that's what we've always done. That's a longer process. New research is now looking at ways to use neighborhood cluster, where you look at a segment. For example, we know that one of the most common visual field defects we see with glaucoma is a nasal step. The second most is an arcuate defect. Now, if you picture both of those, they're not a single spot. They're a series or a neighborhood or a cluster of missing visual fields. And so for most patients, that's kind of how our glaucoma develops. And the same thing for RP and other neuropathies when we look at visual field loss. And so coming to a new system instead of just a single point of testing is really where we need to be, and actually increases efficiency and accuracy. And I can't wait to go into that with you, because that's some of the newer innovation that's taking place. But right now, these current systems use a single test point, and that increases the length of the testing. Patients get fatigue, and that leads to a decline in sensitivity. Oftentimes, you can't just simply, transfer that visual field right into your EMR. It requires additional steps or additional software, really, to be fair. And then the last thing is disinfection. Look at that dome and how close the patient is to it. COVID has changed so much in terms of how patients perceive things and what they comment on and where they want to go to. And I don't know that I'd want to have my face that close to a dome where someone was breathing for the last 15 minutes into, or God forbid, sneezing or coughing or anything in this day and age. And that's what patients look to too. And you can't disinfect these easily. Often disinfection will cause damage over time. It's interesting, we never used to, which now we look at that and think, gosh, the proximity of the patient to that dome is so close. We really have no other options today. So all of these things are in limitations that we look at when it comes to current testing. So where are we today? This is really, to Dr. Farkas's point, perhaps one of the most innovative areas that have happened. And patients are very familiar with this. They've seen, and at least they've seen images of, they've heard of some of these things, the Oculus or HTC, these virtual reality systems that gamers use all the time. So even if they may not have used this, they kind of have seen these images of what this is. And there's a lot of advantages to the Smart System VR headset. And I'm going to really hit on that one today because that's the one that I believe has advantages that make a significant difference. For one, it is more comfortable, significantly more. It follows that same sort of design where there's a strap in the back that allows you, in this case, just to fit closely to the patient. It's easy to adjust. Patients comment that it's very comfortable, very lightweight. You can do this anywhere. You could do it in a well-lit room. You could do it in a reception area, not that we typically do. You could do it in any other areas that you have. You don't have to have a dedicated darker room where the patient's a little apprehensive. It's tablet controlled, so it gives verbal cues to the technician to make the process efficient. They can tell the patient what to do. It's easy to train practically anyone to do this, to be fair, but we know we have our technicians do it. But they find that the guidance is there and it helps them. It's a reminder to them. Eventually they get good at it. They may not need that, but it's so important in the beginning and so helpful. And even my technicians that have a lot of experience will still feel like any sort of guidance helps. It's a reminder. Now, the next ones are really valuable. Binocular testing. Now you're thinking, well, how do you get a visual field if you're testing binocularly? Wouldn't that overlap and you'd not see it? Well, it does test one eye, but the patient doesn't realize that. You don't have to go to a system that's all the left eye for the next 8 to 12 minutes or 15 minutes, and then all the right eye or vice versa. You just put this on, and within, I'm not exaggerating, 3 minutes, you've tested both eyes, but it does it individually. Even though both eyes are open, comfortable, able to look into the distance, the patient can't tell if you're testing the right or the left eye. They just see the stimulus or don't. And so it really allows you to do a very comfortable test in that sense, even though you're testing each eye individually for visual field loss. It's portable. You can take it to other offices. You could do telehealth. You could technically, we thought about taking these technologies to the patient's car while they were waiting, but that was when the early, COVID days when we weren't sure if patients would ever show up again or anything. But obviously, we never ended up having to do that. But the portability of it really, fits in well with multiple practices, with nursing homes, with even different, within our own building, just having different offices we want to try it in or different lanes. It's easy to upgrade to new technologies that come out, such as other types of testing. I think really one of the keys, though, is the active eye tracking. And I've hit this already quickly, and I'm going to go into it specifically in individual slides. But it's the ability to have a system that measures for the number one reason for lack of reliability. And that's the patient who either gets fatigued or loses fixation for some reason. And when that's not present, they start looking for the light. They're obviously going to see it through their macula, and you're not going to get a reliable field. In fact, that's why people say you have to do the first field just to train the patient in the past, so you can do an accurate field the next time. That's not the case with this, because if the patient with the Smart System VR headset decides they're going to look towards where the light is coming from, not only does the image go from a red, target to gray, it shuts down. It stops the test. So the patient then has to refocus. It turns to the correct red color, and then they can resume. So it's extremely important aspect of this technology. And then I really want to get into neighborhood cluster testing. So let me move towards those slides as well. Now, as we look at increased comfort, let's hit a few of these key points. The decreased anxiety during the visual field testing and how we can, improve that for our patients. Remember, this is one of the 2 tests that patients describe as the 2 most painful, quote, tests when they see an optometrist. And I think that makes sense. So one of the ways that this technology gets around that and helps patients to not feel that way, to look forward to coming in for testing, is this binocular testing, as we talked about. You're not occluding an eye. They're not, they're not relying on one single one. They don't know where it's coming from. It seems natural, it seems comfortable, and yet you're testing monocularly. And if you think about that, it's kind of logical. You've got both eyes looking through this system. If it shows up just in the right or just in the left, they can't tell, but it is testing just that eye because you can divide it with these virtual reality systems. It's familiar. Patients have seen this stuff, even if they haven't tried it before. They've seen ads for it. They've seen technology ads that talk about it. They know of their grandson who's a gamer who has something like this, etc. No large devices. They're not holding still for long periods. The average time of a 24-2 to 30-2, depending on test you require, is about 3 minutes to do each eye, so 6 minutes. That's a significant improvement in terms of what's required for full threshold is about 3 minutes per eye. You can actually do quick screening visual fields, very accurate, in 45 seconds. The verbal cues are through the headset. That allows for that education either to the technician or patient can wear the eyewear while taking the test, which is comfortable. You can do it in any setting that they feel comfortable in. If they're sitting in a very comfortable chair, they just put this on and you begin the test. You could even do it, as we said, outside of the clinic in nursing homes and other centers where it may be required. It's also easy for the technician, and I think this is important. Right now, I'd say our biggest need in my clinic is staffing. I actually had to, unfortunately, put my research department on hiatus. That's tough to do. I've been doing research for over 25 years, and in different areas of new drugs and glaucoma and other therapies and technologies, and we just could not keep staff to the point where I finally had to tell companies we're just not going to be able to do any research. And it's been almost a year now since that time. And I think a lot of doctors are experiencing that, even those in regular practice. Those are in primary eye care practice especially, and even those in specialty practice areas are finding staffing to be an issue. So when we can find technologies that are easy, this goes far too. It's easy to set up the patient for the test. It's just simply placed there. Any lighting situations we talked about earlier. The software walks the technician through each step. Even those who are fairly good at this in my clinic, they love the reminders, the verbal cues through the headset, tablet interface so they can view the progression of where the patient's on to tell them, hey, you've got 30 seconds left or whatever might be necessary to get them through those 3 minutes per eye, or if it's a quick test, 45 seconds. Test results immediately export into our EMR system. So it allows it to just upload right at the moment that's there. And there's so much advantages to having that capability. So the next question is, that's great. It's obviously comfortable for the patient. It's easy to do. The technicians can do it. It's faster. Well, is it reliable? Is it dependable for me? And the answer I can tell you is without a question. It's for one, the visual field data being uploaded directly into the EMR allows me to look at it right there as the patient presents. I mean, immediately when they're done the test, it shows up in the record. The transition from manual to automated visual field test really helps a lot in terms of the patient flow that we have. And in fact, I will tell you that, people talk about telehealth and they say, how does it fit into eye care and where do we put it in? I'm actually doing telehealth without realizing it. And I've been doing this for at least since COVID allowed us to see patients. And what I've been doing is I've had the patients come in when it's a comfortable time for them. And it may not be a day I'm there. And they come in, they get their visual field testing, and we typically will do an OR at the same time to just kind of get their hysteresis and their pressures. And that information will be provided to me in the EMR. And then at the end of the day, I call these patients, set up, because they want to do it that way. I say, I want to go over all your results with you. And we do a quick video chat, and we bill for both of those, the visit with the technicians and my impression and plan and diagnosis. And it's great because the patients, what happens a lot is when we bring them in for visual field, then they get bogged down in the system and they're waiting longer and they've already waited for the field. Now they're waiting for the doctor. I find it so much easier for them to come in on a convenient day, the technician to do the testing in any one of the rooms comfortably, and then I evaluate it later, set up the virtual exam and go through it with them as a telehealth exam. It's a whole new thought process, but it's so simple. I mean, I'm kind of doing the same thing in the lane with them waiting around other patients and waiting half the day while I'm getting bogged down, I'm just saying, hey, come in when it's convenient, go home. We'll set up the call to go over it through telehealth and we'll discuss it. The transition is right there. Reduced test time does increase sensitivity. I love the study by Hudson. If you want to take a look at a study that puts everything in perspective, the fatigue effects during a single session of automated static threshold perimetry. It was published in the Ophthalmology Vision Science Journal, which is kind of one investigative ophthalmic vision science, which is a great paper that really shows how much of an impact the time and the fatigue makes on outcomes of quality results that we're trying to interpret. We talked about possible telehealth applications, accuracy of active eye tracking, testing speed, and clinical efficiency. So the eye tracking, I think, is critical, even though I'll go through it again. You have to have systems that allow the entire testing to pause. There's a lot of these VR systems that talk about active eye tracking, but they have simply a crosshair, and they call that the tracking. That's not going to work. Patients can still look around. You have to have something that has the cameras built into this virtual reality system that look at the eye's positioning, such as this technology, where they're looking at the eye's positioning, knowing where it's at, and then being able to show that is not on fixation. We're going to switch over that image from red to gray. Now the patient can look back and make it red again, and it continues, or they can continue to not look properly, and then it actually shuts off within seconds so that you don't get erroneous data. That's active eye tracking. That's a necessity in these technologies that's not present in all of them. Testing speeds, clinical efficiency through neighborhood cluster approach is so important too, but I'm going to cover that here in a moment. So we just touched on this. If you look at this accuracy, and what you're seeing on the left is the red crosshair. That's what patients are focusing on, and that's where their fixation should be. The great thing is at 3 minutes per eye, most patients can do this extremely well, even if it's their first time doing it. Much more, in my impression, and what I've seen clinically than any of the previous visual field tests that we used to do. So it's still so important to have, because you don't want data that's unreliable because they're looking for the dot. They're looking for the light stimuli. But it is, for 3 minutes, it's a lot easier for them to be focused. Loss of fixation will lead to missed targets, false positives, and that's where all of a sudden that nasal step doesn't look like one. Having crosshairs alone, as I've emphasized earlier, is not a guarantee of fixation. And that's where you have to differentiate the technologies. Some have a crosshair and identify that as fixation compliant. Fixation compliant is some system that looks at the eye, that has the built-in cameras that allows the system to know that if they're not looking at fixation, we're not going to collect that data. That's an automated eye movement tracking that improves it and allows for that compliance and test results. And so I tell patients, or my staff, my technicians, tell them you have a red crosshair that's there. If it goes gray, that tells you you're no longer looking at it. You need to fixate again on that central zone. And patients are able to follow that easily. But should they not, the system knows not to collect the data, which is so important to accurate results. Now, if you go beyond fixation crosshairs, this is really what this takes into account. On the left is a perfect example. That's what the patient actually sees to your left, the red crosshair in the center. And the results, as they get to where they need to be and get your accurate results, they are verified through this process. If it goes gray, and you can see that on the right, that's what changes. It's just that simple change, but that's enough to know that they're not fixating where they need to be. That loss of fixation results in pausing the test, also results in verbal notification through the headset to the patient, visual notification on the tablet for the technician to remind the patient, and visual notification in the headset for the patient, plus the change in color. I know that sounds like almost an overkill, but it's not. That's the number one reason we get data that we can't use. That's the number one reason we look at a visual field and we don't have an idea if this patient has pathology or not. You don't want to miss a space occupying mass. You don't want to miss which type of stroke and what's playing a role. You certainly don't want to miss early glaucoma. So I don't think that's any way overemphasized to have all of those steps in place. In fact, I think that's what we need. Now, if the test was 15 minutes per eye, adding this in, that could be an issue for patients. It could add to more problems longer time. That's not the case with these VR headsets and this one in particular. So you're able to do this and increase your accuracy, ensure that the data you're getting is good, your interpretation, you can trust that it's present. And the test resumes once the patient looks straight ahead again, the light turns red, the crosshairs, I should say, and you're able to continue to resume. It doesn't take many of these before the patient recognizes, man, I better focus on those crosshairs. And then their 3 minutes per eye goes quickly. The eye tracking for us as ECPs is that I feel good about looking at the visual field, knowing the results are going to be accurate. Those, I will admit that there were times when we would schedule 2 visual fields on a new patient. One, because we knew it would fail, and that was our practice run, and a second one that I would interpret. And that sounds crazy now that I look back at it. And these were 15 minutes tests, sometimes 15 minutes per eye if we did a 30-2. And again, it's going back a ways, but not that far back. People still have to, make mistakes on their first round with the old technologies and have to often repeat it, and you see changes. I've seen patients where with the older technologies, I was sure they had some sort of glaucoma or some sort of issue, only to repeat it and not see any visual field defect at all. I've seen a lot of the opposite too. And you often get those ones where you see, their reliability is so low, fixation loss 9 out of 12. And you know that it was a useless test. That's not going to happen with these technologies. There's no possibility with this one in particular because of the active eye tracking. It's consistent no matter who runs the test or where it's run. It's accurate, reliable identification of disease, or more importantly, those subtle progressions that occur that are so critical to knowing we have to modify the glaucoma management in particular. And it helps me be confident in the treatment plan. Those days in the past where we used the standard visual fields with the domes, and we'd come up and look at the field and we'd say, wow, that looks like a significant amount of loss. We got to be much more aggressive. And then when they came back, 3 months, 6 months later for their next visual field, we'd say, wow, we put them on too much drugs because their field improved, and the fields don't improve. Their reliability had improved because they had a practice. And so it was unfortunate because it didn't give us confidence in our treatment plans and how we decided to manage these patients. With this technology, I assure you, you will be confident when you look at the visual field. You'll know how to respond, how to treat the patient, how to manage them, and you'll know that the next subsequent test will help us to determine if there's progression. I remember when I was first, getting started, I did a VA residency before I did my cornea fellowship. So my first love was actually posterior segment, glaucoma, retina. Then I came back to retina again about 4 years ago. But nevertheless, I remember one of my instructors at the time told me, yeah, just make sure that you get, before you treat any patient, at least 6 IOP measurements and at least 3 visual fields. Then you can make your plan. And unfortunately, he was saying that simply because there wasn't reliability, especially in the visual fields. That's a lot of tests to rely on before you actually come up with a plan for this patient. And it took 3 to 6 months. Now, to his credit, glaucoma is typically slow progressing. You do have time to kind of do extra tests, but wow, if I could get reliability on 1 test and 1 or 2, maybe 3 max IOPs, that's a lot better way to manage these patients and come up with your treatment plan for them. And that's where we're at today. A single field and 2 to 3 IOP measurements, we come up with the target, we come up with where we're at. Of course, OCT is critical to that too, but we're able to, with those 3 tests, really have an idea of where they're at. Hysteresis plays a key role in addition. Neighborhood cluster testing, proven speed and efficiency. This is the one I've been anxious to get to, and I kept hinting at this one throughout our entire talk today. This has actually been extremely studied. If you go through abstracts and papers, you're going to find about a dozen in this area. In fact, I was shocked as I was working on this presentation and working in terms of getting the research to review around neighborhood cluster testing, how many papers already had existed. And it's proven speed and efficiency, which leads to reliability. So let's talk about what that is. All right, so first of all, speed matters in this case. Patient comfort leads to more accurate results. We looked at some of the studies related to that earlier. Patient fatigue results in lack of reliability of your test. And for us, that clinic workflow is critical. If I have a patient that's going to take 15 to 20 minutes because they have, issues related to the fields, got to repeat them 2 or 3 times, put them back in the system, that workflow is not working. They can only use a dark room. Today, we can do this anywhere, as this patient to the left is at. Clinic workflow is quick. The speed of which this happens is quick. The reduced fatigue allows them to come back and say, okay, I don't mind doing that again, to see where we're at. Individual points and global indices do not provide the ideal combination of sensitivity and specificity alone. What we mean by that last bullet, and this is an important one that I really want you to zone in on. If you decide that you're just going to do individual point testing, which is our traditional dome type visual fields, single point, one eye occluded, looking for those individual spots while the patient stares at a single point in the center, and we measure the periphery. That alone doesn't provide the ideal. It does provide some sensitivity, but not specificity to the disease. If you do global indices, where you're trying to test large areas all at once, almost like the old tangent fields that we used to do, you don't get any specificity, in terms of how these two work together. And the goal is to have both. If you look at the science of the ideal tests from a diagnostic perspective, you want high levels of sensitivity, meaning that it picks up on disease, and high levels of specificity, meaning it determines what the disease is. And the goal is to have both of them. So this neighborhood cluster testing is the key. If you take a look at the studies, it is more likely for vision loss to occur in clusters. Now, I do encourage you to scan that QR code to your right. That's going to give you all those references we talked about earlier, and you'll be amazed by how much science exists in this area and how every single study points to this is the direction we need to be going for visual field testing, known as neighborhood cluster testing. It's more efficient and more accurate. So it detects the larger clusters. And I keep going back to think about the most common field loss you see in glaucoma, but this could apply to any patient who's had a stroke too, where you've got a hemifield loss and other things like that. But think about glaucoma. You've got nasal steps, not a single spot, but a nasal step pattern. Arcuate's a better example because you have this kind of arcuate pattern of field loss, which describes that neighborhood of loss of vision. So it tests the larger clusters such as those. And then within each large cluster, it's explored more closely where they can look at individual points. And that's what you're seeing on the left. They look at the larger zone areas and then go into them in detail with individual points, especially if there are areas that are lost. The information from the neighboring positions help define the shape and pattern and create more accuracy of those patterns, which are pathognomonic or diagnostic for glaucoma in particular. Fewer presentations are needed to detect those deficits, to identify those key patterns, such as arcuate loss, such as field loss, such as nasal step, such as the patterns we would expect that are in a neighborhood as far as the testing approach. That doesn't mean it misses spots within it. It goes into them individually because it knows it needs to identify the level and density that's there. This is probably a great graph to kind of put in perspective. If you were to look at sensitivity by an individual spot point, and I talked about that, you have really high sensitivity. You know that there's a loss because you're looking at each individual spot, and then you're going back and looking at the decibels and saying, wow, that is depressed in that spot. And so you got good sensitivity, but it doesn't tell me a lot of specificity. And that's the kind of visual field testing we've been doing from the past. And that's what I love about what we're talking about today. It's not a case of saying, hey, we're just making it faster and we're making it easier. We're improving what we did in the past because we have this VR technology to do it. If you did global indices, looking at large areas of zones that might be missing, such as a nasal step, such as an arcuate, such as a hemifield, such as an RP where you've got obviously significant peripheral loss, that's good specificity, but I don't know the sensitivity in there. I don't know what's progressing. I don't know what's missing because I don't have that sensitive zone to pick up on it. That's there even though I have specificity. And guess what neighborhood cluster testing does? Look at the bottom. It gives you the optimal high level of both sensitivity and specificity. So you maximize your accuracy, high levels of both of those indices, which are critical for your diagnosis, not only of any sort of monitoring or progression of loss, it's also for identifying the disease. And guess what? In all these conditions, you kind of need both. If you're managing glaucoma, you need that specificity to say, yes, this is a glaucomatous field loss. But then you need the sensitivity to say, wow, this is a fast progressor, or hey, we're keeping things very consistent on every exam because we have them on the right therapies or the right treatment. That would apply to a case of a neuropathy. It applied to retinitis pigmentosa. It would apply to geographic atrophy, where you might do a 10-2, where you need to have both the specificity and the sensitivity. So the list goes on in that ability. And again, there's another scan for the abstract references related to that. If you didn't catch it, I think those are so important to understand how much research has already gone into this neighborhood cluster testing and why you would want to have that if you're managing any of these diseases, and why you would want to have it from a visual field perspective. So the clinical benefits of neighborhood clustering are what we talked about: accurate, efficient. Obviously, that speeds things up. If you check for a cluster area and then go into it in detail, you can increase efficiency, but you also increase accuracy because you're finding where that loss might be and then identifying the individual points. Less patient anxiety. They're not sitting there for this extended period of time because there's so many stimuli individually hitting every point. Their attention's there, fatigue's reduced, the shorter testing time. I have patients who finish these and say, oh gosh, I can't get over how quick that was. I remember what it used to be like. This is such an improvement. I don't mind doing these. I'll be back for my next test in 6 months or whatever it may be. And from our standpoint, it's just better for patient workflow. If I have an empty lane, empty side room, empty area, we could do this testing as necessary. And we've had cases where a patient comes in and there's some neurological issue, and I'd love to have a quick field, but I'm not going to have room with her. If my other doctors who I practice with are using the visual field for the glaucoma testing, the older one, you can't get them into that room. And I work independently. I have my own technologies. I work within a clinic. I bring my own stuff. So I have this great advantage that I can do what testing I want in any room I need to do when I need to do it. And that's huge patient workflow advantages. So what are the key benefits of the Smart System VR headset? I have to emphasize that the only company makes Smart System VR headsets is M&S Technology. They've been a very trusted company in optometry for decades. You think about all the technologies you have, or may not even realize you have, that are M&S technologies. Such as your visual field testing and machines, and now this VR headset. And so many, they're a company that people have relied on. And they're also known for technology. So this is so much in their field of what they do. And these benefits, obviously, as we went through kind of earlier, are more efficient approach, positive patient experience. All of a sudden, what Dr. Farkas talked about at the beginning, how patients dread these tests. How we find a better way? Well, this is not just we've got a visual reality headset that allows us to do the same thing easier. No, this is an improvement beyond that. It's not only patient comfort, it's increased accuracy. It's using technologies like neighborhood cluster testing, active tracking involvement that we couldn't have with the older technologies that were there. If patient wasn't looking, we only found out later on when we looked at their printout. We got the visual field printout and it said they had 12 out of 15 fixation losses. And we said, well, let's toss that in the trash. Now it's electronic. We'd have to keep it anyways. But that's what we did. It was after the fact. This is real time while it's happening within that 3 minutes per eye time frame. Better overall patient experience, and I can attest to that. Improved clinic workflow, because that's kind of how I run my clinic as I go into Kentucky Eye Institute. Reliable results. You don't have the days of 3 visual fields and 6 pressures. Today, it's this visual field, this one, you can count on it. It's there. If patient wasn't looking, the machine would have shut off and had to start again. So you're going to get reliable results. Plus, I think because of the short time, you don't get that fatigue and all those other factors that affect our reliability. And as things continue to improve and software improves and new technologies like this are advanced, you can incorporate them right into these headsets. And so for this one in particular, as we see that, the neighborhood cluster testing is the most reliable, most effective way to do it, it's incorporated. Now that's already in place. But as new things like that might happen and might develop and new science comes out, they're easily upgradable into the systems you have without having a whole new set of software, of hardware to come in. And if you happen to be going to the AOA booth, and don't leave because we're going to go over, Q&A, we're going to take all your questions tonight, and if you have, but if you happen to be at the AOA in Chicago, booth 3105, you can schedule a demo to see what I'm saying is exactly what you'd experience there, and be able to understand how these VR technologies are really where we need to be today and for the future. With that, I'll pass it back over to Adam, where we have enough time now to go through some Q&A.
All right, great. Well, thank you so much, Paul. And I'd also like to introduce Mike Umali, the National Sales Manager at M&S. He's been intimately involved behind the scenes with the development of this device. So, Mike, are you there?
I am, Adam. Yep, thank you.
Okay, great. So I guess before I get to everybody else's questions, and by the way, if you want to ask a question, remember on the right side of the screen, there's a box there that says questions. Feel free to type in there and I'll verbally ask both Mike and Paul questions. But Mike, I have to ask you before I get to anybody else's questions. At ODwire and CEwire, we develop a lot of software, very traditional software, right? Stuff that runs on the web. VR stuff is well beyond our pay grade, my pay grade. And so I guess I was kind of wondering, my own personal knowledge of VR is basically loading up the Oculus Quest and playing Beat Saber. What was it like kind of developing, medical software essentially that works inside of VR? What was that whole process like?
Yeah, Adam. So, M&S has been in business for 32 years, writing software specifically for the eye care industry. ECPs know us from the visual acuity charts that have been around for 30 plus years, and we've got 36,000 of those in use all over the world. What they might not know is that all our software development is done in-house by our own programmers who've been with us for 15 plus years. So when this opportunity presented itself, we knew it'd be a tall task, but this is what we do. And everything we write has science behind it. It's peer reviewed and validated. So, not only is this top-notch software written by a team with just massive experience in the industry, most importantly, the headset is going to be reliable and accurate, just like Dr. Karpecki said.
Right. And so we have a few questions coming in, so I can maybe just ask you guys. I'll throw them out there, and you can sort of give your opinion on this. So first question was, will objective fields play a role in the future? Is this something that you guys see on the horizon in eye care? And I don't know, Paul, if you want to take a stab at it.
Yeah, I could first try to begin with. So that's another, innovative technology. And I'm always big on innovation. I think that's what allows our profession to advance. It allows our patients to continue to come to optometric offices. It allows us to have better workflow, less burnout, so many advantages to incorporating technology when it's sound. And when you do the research and realize, like this technology here, like smart VR set, that this fits in. So objective fields, another potential area where, patients don't have to actually respond and click anything or look into a field, and can, that allow them to, utilize it and get some test measurements based on pupil changes and other things like that. And, there could be technology that could play a role. It's one that we also want to scientifically look at and evaluate where it fits into. I will tell you that I do like the fact that this technology allows the patient to actively participate in their results, in their care, to feel like they're part of that to a point. I do like the fact that it's a simple system that's quick and well, but I think there's a place for all technologies that are advancing. My concern would be if I was a company making the old-fashioned dome machines. I don't see why we would continue to keep that around. I think we would want to advance to where we have the technology that patients can leave saying, gosh, doctor, what a difference. I will come back to your office. I feel like it's there. And I know that's there with this headset and with this VR technology. And perhaps other objective technologies will fill some of that potential as well in other areas. There's plenty of room. You look at all the practices out there. There's 40,000 plus ODs, 18,000 plus MDs. There's a incredible opportunity for advancement. And if there's one area we have not advanced in, it's this visual field testing. And I think that's why it shows up as #1 on the quote pain list for patients when they see an eye care practitioner. And so I think there's a lot of room for improvement, and I'm glad to see this technology, and there may be room for others as well.
Great. And a question here, what is the cleaning process for the headset in between patients? Or I guess, Paul, what is it that you are actually doing in your clinic in terms of cleaning?
So that's a big advantage. You know, I'm still not sure how you are supposed to clean the dome ones without damaging it. You know, fortunately, I'm interested in my practice. So I actually go into my practice. I'm at Kentucky Eye Institute. I'm affiliated with them. They're a great practice, great cataract surgeons, great group. But I have my own clinic. I have my own key people and my own technologies and my own staff that I bring in, and I run the services out of it, which works out great on the days we're out there. And so I have mine. I don't ever use the old technologies anymore, or a lot of the stuff that's there. So I go back and ask them, you know, and they honestly didn't know the answers. They're like, I'm not sure. I know we need to. I know patients have asked that question many times. I'm not sure. With the VR headset we're talking about today from M&S, the Smart System headset, you just have to clean the contact points that are present. You know, your routine, alcohol. Otherwise, you don't need to clean the ocular system. You don't need anything on the front. You don't need to clean anything where you're dealing with that aspect. You're just where the patient contact zone is that could be related to that. And that's a very easy approach. It's fast, it's efficient. The patients, you could do it in front of the patients if you wanted to, so they could feel very confident in what's there. And it's just the head components that fit on the front and back that allow you to place it on a patient. There's space there, allows for it, makes it easy, and you can do that. Mike, is there any specifics that you would recommend when it comes to cleaning of the system that go even beyond what we do?
No, I think you're spot on with that, Dr. Karpecki. I mean, an alcohol wipe, a sanitation wipe. I mean, this product has been in development for a year and a half, and I've got mine here on my desk, and I wiped it down with alcohol wipes, Clorox wipes, and it hasn't compromised any of the padding or the cushioning or the contact points. So we typically say grab an alcohol wipe, wipe it down, let it dry, and off you go. So yeah, it's a very quick and seamless process.
Great.
Perfect.
So another question here. I don't think you actually went over this. This is a good question. What types of tests does the system actually have built into it that doctors might be familiar with? Because I don't think we actually went over that.
I'm so glad you asked that question. You know, that's an important one, and I kind of think I skipped over that as we went through the lecture, but it is all the standard tests that you want to have. It gives you your 10-2, so that's where you're looking at your specifics related to obviously the macula and that central vision area and some of your more advanced glaucoma patients where you're concerned about fixation loss. You have your 24-2 and you have your 30-2. So everything that you would consider that you'd want to test, there's no missing element to these technologies that are there. And what's also really, I think, important too is the fact that with this technology and how it works on that cluster kind of neighborhood cluster testing, you're going to get that reliability on across the board on each one of these tests as is necessary for you to achieve those components, both from a sensitivity and specificity. And so there's no loss in terms of that capability regarding your visual field test that you want to order. The other thing that I think is really important if you look at neighborhood cluster testing is that it also takes into account the GCC component. And we know that that is so critical for glaucoma progression. In fact, that's what we look at when we're looking at OCTs. And that actually, there's studies, and remember, if you scan that QR code, you're going to get one of the studies in there in particular talks specifically about the GCC complex and how the accuracy of visual field testing related to that increases when you use neighborhood cluster testing, which is part of this. But that you would get within your standard 10-2, 24-2, and 30-2.
Right. Ooh, interesting question here. Is the system currently being used in nursing homes where they offer remote on-site eye exams for patients that aren't mobile or are in a wheelchair or confined to bed?
Well, I can tell you in my clinic, we have wheelchair patients. I don't practice in nursing homes, or I have taken it from from a clinic in Lexington to a clinic in Indiana. So I have had some portability already with the technologies, and we do that with a lot of our systems that are portable between the two clinics. I'm rarely at the Indiana office. There 4 times a year, but I do take that over there. Portability is really such an important thing. So I got to assume that's going to be the same thing in terms of nursing home. But yes, I think there's so many patients that are mobile challenged, that are in wheelchairs, that are, as you think about your glaucoma population, where it's so difficult for them to reach in, put their forehead up against the bar in there, get it positioned really comfortably with the old systems, that this is such a relief for them, that ability to just simply place it, position it, know that they're looking through, they see the red target, the square crosshair, and they're able to go ahead and just do the test. And because of the speed of time, it's very comfortable. So I've had, certainly that makes, experience regarding patients who are in wheelchairs with great success. I don't work out of nursing homes, but I would assume my own experience would be very similar. Mike, you obviously work in sales with doctors across the country. I got to assume there are some doctors that are using this in nursing homes and other areas where they have to bring it with them.
There are, Dr. Karpecki, and yes, I mean, the portability part of it is absolutely huge. And I just wanted to touch on more of the testing algorithms that are on there. So yeah, in addition to being portable with it, which has been a huge deal here early on with the headset. And as you mentioned, you can do a 24/2, a 10/2, and a 32. There's also a screening test and a super threshold test on there that's about 45 seconds an eye, which you touched on. But you can also do FDT testing on the headset as well. So some ECPs who have patients who are accustomed to doing FDT testing, you can run an FDT test right on the headset. There's also a ptosis test, an Esterman test on the headset as well. So you got a lot of your visual field bases covered, but in addition to the visual field testing, doctors like it because, yeah, when you're doing testing, whether it's in the office or at a nursing home or remotely or off-site, you can also do contour stereo testing. There's a color vision test and a contrast sensitivity test. So the headset, not only does it give you everything you need visual field-wise, but yeah, it covers a lot of the pre-testing stuff you would need to do prior to getting the exam started.
Great. And in fact, a lot of people have already asked about the Esterman test. So I'm glad you brought it up because we've now had several people ask. So that's excellent. And follow-up question here. This is an interesting question. We have a large Canadian audience, actually. Is the headset available yet in Canada, or is it just the US?
It's definitely available in Canada as well. Absolutely. Yep.
Excellent. And question about the reporting. What do you do about progression analysis? Is there reporting available? I know you mentioned that it hooks up with a tablet. How does that all work together?
Yeah, definitely. So every headset comes with a Microsoft Surface Pro. And when we kind of launched the product, the reporting, a lot of ECPs said that they needed the report to look just like, a report looks on their standard visual field device, their standard perimeter bowl. So as far as look and feel and aesthetics, the report's going to look just like ECPs are accustomed to the report looking. And every headset comes with a Microsoft Surface Pro, like I said, and that's going to be kind of the driver for everything you want done on the headset. It's got a very clean looking interface. It's very every test and every button is laid out very logically. So simply tap or click on the test that you want done, automatically sends it to the headset. And like Dr. Karpecki said, there's audio instructions in the headset kind of walking the patient through the entire process. And the technician can follow along right on the Surface Pro to see how much time is left in the test, as well as actually watch the report being populated in real time. So everything's driven right from the Surface Pro. When you're done, the report pops up, takes up the full screen right on your Surface Pro, and that can immediately be exported into a PDF and transferred wherever you want it to be.
Got it. A question here, that's an interesting one. Does the device have the ability to do plaquenil field testing?
Not currently, but that's definitely in the works. Every headset purchased comes with 3 years of free software upgrades. So we're undoubtedly kind of in the beginning of headset technology, and in my opinion, I mean, it's here to stay. It just makes so much sense practically as well as scientifically. And like I said, we do all our software writing in-house. So yes, that question has come up a lot, and that's definitely on the table to be added. And with the 3 years of free software upgrades, that's a free software upgrade when it does come out to anyone who purchases the headset.
Right, and so just to be clear, the upgrades are sort of what people are used to these days, where it's sort of over the air, and the upgrades get installed that way.
Exactly. Yep, that's exactly how it's done. We can take care of that remotely, and yeah, that's free for 3 years. And one other thing we're working on here is we're working with a major institution here in the Midwest, and we're going to add kind of AI into the algorithm, where it's a quick test already, but with the added AI, based on how fast the patient clicks, we'll be able to even reduce that test time even more. So yeah, all that stuff is on the table, and plaquenil testing is definitely one of them, and that's gonna undoubtedly be on the headset here.
Right. Interesting question here, and I guess I hadn't really thought about it. How is refractive error compensated for by the headset, or is it necessary at all?
Well, they can wear their spectacle correction right in there. That's what makes it so comfortable too for the patients. And that's a great question. It's one I probably should have included as we're putting together this presentation. That's such a valuable component, not only to their comfort, hey, these are what I'm wearing and this is the simple thing to do, but also you don't have that extra tech time to put in different trial lenses and get it lined up and make sure it works in there. They wear what they're comfortably able to wear. And that's one of the big advantages of this type of testing, where you just place it right in front as you need to of their of the VR headset.
Right.
Yeah, that's right. You wear your distance correction right under the headset itself, and it's certainly big enough to fit even larger frames. But yeah, I mean, progressives, bifocals hasn't been an issue from what ECPs have reported back. So yeah, you wear your correction right under the headset.
Right. And so again, a question here about field comparisons and progression analysis. Is any of that software available yet, or does it just sort of take the output and export it into the EHR? How does that work?
So there is built-in progression analysis software already in the headset. So if a patient has 3 tests of a 24/2, for instance, on the right eye, it will automatically generate right on the Surface Pro a progression analysis report. So that algorithm and that technology is already kind of built in there. So yes, there's absolutely progression analysis software in the software.
Right. Kind of a COVID-related question right now. Is there any problem with wearing masks and having fogging within the headset?
Not really, not from what doctors have reported. Yeah, that's definitely a concern, but it hasn't been one that's been brought up. And I've taken my test here on my headset with my mask on multiple times, and no, there hasn't been a fogging issue with the lenses. It's on your face nice and snug, but you can still breathe out of there pretty comfortably. So no, that hasn't been an issue here with the headset.
Right. And question about implementation. So I think you mentioned it before that it's pretty easy. It's obviously tablet driven, so it can't be that hard. What's the actual process like of getting it set up in the office?
Yeah, look, it's very straightforward. And this is just from ECPs using it. We were very cognizant of it being having the interface very intuitive and as straightforward as possible. And with the Surface Pro, the interface is just extremely easy to navigate. You just hit 30-2 and it sends it right to the headset. And the patient then gets those audio instructions and they're making them feel nice and comfortable. There'll be a learning curve initially, if nobody's done a visual field test in a headset before, but it's not steep. I mean, it's not steep at all. With the instructions in there, it's really, really hard to screw up. And we've made it as comfortable as possible for both technician to administer and patient to actually take. So no, with the way it's laid out on the Surface Pro, simply hit a button or tap a button with your finger and it sends it right to the headset and off you go.
Great. And question here, does it require any sort of calibration?
So there is a calibration process that needs to be done, but if you do it kind of just one time, what happens is that the built-in cameras will find your pupils while you're taking the test. If somebody is wearing their glasses while taking the test, there's a specific checkbox that needs to be checked to basically let the headset know that, hey, you're trying to find the pupils through the correction in the lenses. We tell the software to account for this, and as long as that checkbox is checked, we pre-calibrate all the headsets before we fire them off. So once they arrive at the office, off you go. If somebody's wearing their correction, just make sure that checkbox is checked. If they're not, just make sure it's unchecked, and off you go. Those cameras will find the pupil, and if you gaze ever so slightly to the left or to the right, like Dr. Karpecki said, that fixation target will change color, the test will pause, and it'll only resume again once the headset recognizes that the pupils are back on the fixation target.
Got it. And a bunch of questions have come in about cost. I don't know if you could speak to that, sort of what the cost of the entire system is.
Yeah, so the headset's going to be a one-time fee of $10,995. It's going to be a one-time fee, and it comes with three years of free software upgrades and a 1-year warranty on all the hardware. We do have options where you can, we have an option for $340 a month for 36 months, if that's something that an ECP wants to take advantage of. So there's multiple ways to kind of purchase the unit, but the list price for the unit is going to be $10,995. And like I said, that's just the one-time fee. And you're billing for these tests just like you would, on the more traditional perimeter bowl devices.
Right. And I had one more question here about the durability of the device. And I don't know if you put it through any torture testing, but if it's like any other consumer VR, I noticed from experience, they can take a pretty good beating. Is it a consumer sort of grade VR unit that you were using to base the technology off of?
It is, yeah, it is. So, I mean, the headset, a lot of these headsets now are used for gaming, and like I said, I've had mine for a year and a half, and we, with all the R&D that we do, I mean, this headset has gone through a lot, and I can't tell any degradation from the padding or the side straps. It's still really, really rock solid. So I don't foresee that to be an issue. Some of these headsets will be used a lot. I understand that. And the headset quality itself is industrial grade, and it's top of the line quality. So no, I've been using mine for a year and a half every day, and it's been rock solid.
Right. And I know the consumer grade ones, at least here, we walked into walls with them many times for better or worse, and they've survived. So question here, as a relatively new tech, what kind of support is available if someone's having tech difficulties?
Sure, absolutely. So at M&S here, I mean, we've hung our hat on service for the last 32 years. So undoubtedly, there's some ECPs on the call now who have used our visual acuity charts, and our service is second to none, in my opinion. So if something happens to the headset, 8 to 5 Central Time, you'll get somebody on the phone immediately to answer any question at all you have on the headset. And that's a live person ready to take your call. So yeah, we're here to support the product. We plan on being in business for 30 more years. So we've been so successful because of that service. So anytime somebody needs anything, I mean, 90% of these calls can be taken care of over the phone. But look, if something happens to that headset, we'll be able to ship out a loaner headset at no additional cost to the ECP while we take a look and try to diagnose what the problem is with the defective headset. But look, our service is top notch and it's second to none. And the same quality service that you get with our visual acuity charts, you'll absolutely get with the visual field headsets.
Right.
Yeah, and I can attest to that. I tell you, we've had our visual field system in Kentucky Institute for over 2 decades. Now, I haven't been there for over 2 decades myself, but I've been there for, I guess, almost 9 years now. And I will tell you that I'd be hard pressed to find a company more dedicated to service than M&S Technologies. They really go above and beyond. That's what they're, I guess, known for. And so I think it obviously is applied for decades now.
Right. And we're running a little bit low on time, but I do want to get a couple of these more questions in because I know that this is people are definitely interested. So one question is about the output. I don't know if we saw a little example of it previously. Is it similar to what you might get from a Humphrey in terms of being able to interpret the output?
It is for me. I'll let Michael go through that too. But that, I think, is so important that you have something you're familiar with, even if it's an easier, simpler, better technology to do the same thing. You want to be able to say, okay, I've spent all this time understanding what a visual field should look like and the key measurements and decibels and all the info that comes in, and I can tell my sensitivity. You want to have that same pattern type of recognition. And I can tell you there's been no transition as you look to these, and I've examined these printouts that are related to it. And while we showed you one there, I think that's something that I'm glad the company was big on, is trying to keep it consistent with what we're familiar with. But Mike, I'll certainly let you answer as well.
Yeah, absolutely, Dr. Karpecki. So yeah, you'll be very hard pressed to kind of find a difference as far as how the report just aesthetically looks. So everything from the fixation losses to false positives, false negatives, the duration of the test, the mean deviation, it's all going to be there. So there shouldn't be much of a learning curve, if any, as far as interpreting what the report looks like on the Surface Pro when you're done doing the test on the headset.
Right. And we have time for one more question. And this is an interesting one since the tech is so new to everyone. The headset itself is rechargeable, correct? And can it last an entire day in clinic without dying?
Yeah, so it is rechargeable. It is rechargeable. I always say when not in use, kind of plug it in and charge it. The headset comes with 2 remote controls. You only need one for test time, but it'll last about, I would say, 3 hours of continuous use. The Surface Pro will get a little bit longer battery life there, but there's a constant connection between the headset and the Surface Pro. So I would say about 3 hours of continuous use, and when not in use, I would keep the device charged, and you can use the device while it's being charged. Yeah, that's kind of how long it would last with continuous test time.
Oh, so interesting. So does it charge using like a standard USB-C cable?
Exactly. Yep, it's a USB-C cable. It comes with one, and comes with a splitter for the 2 remote controls. But yes, it's a USB-C charge, and yeah, you can charge it while you're using it.
Right. So you can get an extended cable, and you can actually just use it tethered like that if you needed to.
That's right. Exactly.
Yep. Great. Well, all right. Well, Mike, Paul, thank you so much for being here tonight, and thank you everyone for showing up here tonight. And an archive of this show will be up on ODwire, and right beneath the video when you're watching it, there'll be an area for questions, and we'll send you the URL to the archive as soon as we have it up. So again, thank you everyone for coming tonight, and I guess we'll see everyone online.
Thanks, Adam.
Thank you.